Hello, and welcome to the Health GoLive webinar series. Today's episode is brought to you by your friends at Icario. We would like to remind you that the Q&A feature is available, so feel free to send in your questions and comments throughout today's webinar. We would love to hear from you. And with that, I will turn it over to our moderator, Lisa Barry.
Thank you, and welcome everyone to our webinar today on From Data to Action, using member-reported data to mitigate risk. I am the head of external affairs at Innovacer, formerly the CEO of Civitas Networks for Health, and I care a lot about how we use data to improve health outcomes. In this discussion, we'll be talking about the particular case of plan sponsors and how they can leverage different types of data to really understand and improve risk mitigation and really improve those health outcomes. So we'll be talking about different strategies to leverage combinations of survey responses like health risk assessments and other survey responses that can identify those areas of rising risks. And I have two incredible panelists with me today, so I'll ask them to join the webinar now, Corey and Vandana. And I'm gonna just hand it over to Corey to start the introductions, talk about yourself, talk about Icario, your company, and what your thoughts are on this big topic before we dive into the discussion.
Terrific. Thank you, Lisa, and thank you for moderating this panel. Thanks to Health for monitoring or moderating this this event. Really excited to be here. I'm Corey Bussey. I'm the Vice President of Strategy and Sales Enablement at Icario. Been with the organization for about 7 years. Been in the healthcare space for about 30, in varying jobs in health plans and PBMs and medical devices and pharmaceuticals. And in the last 10 years in health IT, health tech. And so it's sort of the career trajectory along with the trajectory in the market has been kind of a similar path where as more and more data have become available, and we've in my view struggled as an industry to kind of make heads or tails of it and to put it to best use. This felt like a really timely topic for us to discuss, to really kind of dive in and go beyond even the context that I come from. Icario came from 3 different companies that merged together back in 2021, 2022. And all of them had their roots in what I like to shorthand is getting the member to do the thing. What that does is, and we're not getting away from that. We're still all about getting the member to do the thing, but we're recognizing that there is something vastly more important about driving additional moments of influence within the context when we have a member engaged to get them to do the other things that we want them to do as well. And along the way, as we're learning more and more about those members, utilizing the data that they've been so kind to share with us to help them live healthier lives. And so that's kind of the context that I'm coming from, this long career where I've been waiting for a moment like this, where we have the opportunity to really take full advantage of the data that our members are sharing with us.
Yeah, I really resonate with that because I feel very much that we have been doing such a disservice to members and even to plan sponsors and everybody else in the healthcare ecosystem of just simply not being able to use and ingest the data that are available to us. Folks can probably, remember as a patient, as a member, providing all of these data and having them never be used to even just make your experience easier and less administratively burdened, to say nothing of improving your health outcomes and improving the coordination of your care. So we'll talk more about that in a minute. Vandana, how about you jump in with your introduction and then also talk about your work at 8B Advisors and what you've done in the past as well and your thoughts on the space.
Okay, thank you, Lisa, and thank you, Corey, for inviting me to participate in the panel in health. My name is Vandana Barani. I'm the managing partner of 8B Advisors. We're a boutique consulting firm that supports payers, providers, and technology companies in achieving their quality, risk adjustment, operational, and interoperability goals. My specific experience has been in the health plan space or the health ecosystem, the healthcare ecosystem for over 20 years, really focused on just what we're talking about. How do we truly engage members? How do we truly achieve the outcomes, not just of a payer, not just of a provider or a company, but really in and for the members that we are serving. Being able to integrate and weave that information that we receive and the data that we are able to capture across the continuum of services, whether it's data that we're getting from the member from a particular state for some of our plans, from CMS or from the transactional data. It's all about now, I love what you said, Corey, getting the member to do the thing. For me, it's not about getting them to do the thing, because I think many of our members want to do the thing, and they are looking at how they can, they are considering how they can. It's about how can we support them in being able to do the thing. And we now, like you said, have more of the data to be able to really truly understand and impact them.
Great, thank you both for that. I would just note that as folks are listening, if you, and as we're discussing, it's okay to put your questions into the Q&A function in Zoom, which you'll see at the bottom rail of the screen, and we will take a look at questions and get to them as soon as we can. But we will have, just a discussion here. We'll talk generally. We have a few questions and things we want to explore a little bit, but definitely, welcome questions from attendees. So let's just get more specific and say, make sure we're really clear about it. Why is self-reported data so important for identifying member risk that claims data alone might miss, right? I think this is really, as we all know, sort of the apparatus of data for plan sponsors has very much been, for many, many, many years, claims data has some strengths, has a lot of weaknesses, a lot of stuff is missing, and all kinds of delays and things like that. So, let's talk specifically, why is this self-reported data so important for identifying member risk? Anybody want to jump in? There's no rules here.
I will, and I talk a lot about burning daylight on members, right? And the delays you talk about, Lisa, with regard to the lag for claims data, is so important. And I hear practitioners, I hear health plans, I hear members themselves complain about the delta between when something happens and when it shows up in claims. And what we see in practice is, and it becomes sort of the nature of the siloed nature of health plans, where you've got P&Ls in risk adjustment or quality, or even in operations, where we are taking a linear approach to so many things. So we'll conduct a survey like an HRA or a CAP survey, pre-CAP survey, and we will field the survey, and that takes time. And then we'll collect the data, and that takes time. And we'll analyze the data, and that takes more time. And then on the basis of the data, we'll concoct a program meant to address what we found in the insights, and that takes time. And then we'll field that program. All the time we're burning daylight on that, remember. And so it's so important, I think, for us to be able to pull forward, and we have the opportunity with the data that are available to us today in a way that we couldn't 10 years ago. We have the data and the apparatus today to pull that interaction forward, and really start to address member needs in real time, particularly as we're talking about things like social determinants of health and barriers to care, in a way that I think just didn't exist when, some of us started our careers in this healthcare space. That's where I kind of start with all of this, Vanda.
Yeah, and I totally agree with what you said, Corey, and I think about it kind of at a big picture level. For as long as I can remember, we've been talking about medical-centered homes, personalized care. We're talking about person-centered care. I've heard of the concept of, a more individualistic side of population health. How do we find the space in which we can truly understand, identify, develop, assign, and monitor where a member is at any given time? Historically, like you said, Lisa, we've used transactional data. That's what's been available. The transactional data is just that. It's about a transaction. It's not really indicative or informative as to where a member might be today versus yesterday. Maybe yesterday their car was working and today it's not. And so it's really about being able to have a more a real-time understanding. Now we can't be that perfect, right? We can't be yesterday I did and today I don't.
Right.
But the more information that we have, the more opportunity that we have to be able to integrate and aggregate data that is coming from the member about their preferences, about what's happening to them, and be able to really rationalize that across the transactional data, the better opportunities we have to truly support and impact their care.
Yeah,
And I
those are
think
really, oh, sorry, go ahead, Corey, keep going.
just one more point on that. I hear from a lot of plans that they don't use a lot of member support or member reported
Yes.
in support of things like risk stratification and so on. And I think that's understandable. But at the same time, there's an article from the American Journal of Managed Care from 2022 that kind of looked at the difference between predictive models that use data sources like SDOH data and ADT data and demographic characteristics, rather than the traditional approach, which is through regression analyses of claims. And what this peer-reviewed journal article found is that the former, the predictive models that use SDOH and ADT and these member data, these often member reported data, consistently identified a higher proportion of the highest spending members than compared to the old way or the traditional way of doing it. There is something to that. And what was more is that the members who were deemed the highest risk by the former models using the member reported data also then went on to have higher spending than members who were deemed at higher risk by the traditional models. So there's something to what the members are telling us that we need to very much take into account, lest we miss big opportunities to do right by them and their care and do right by the system in the reduction of costs that go along with missing those opportunities.
Well, and also, I think you mentioned this as well, we do have better data today, and we have better technology today as well, and the ability to manage and incorporate those data. I'm thinking specifically about data governance, which is really important when you're mixing different types of data sources and data, provenance, right? Completeness, quality, all of those things. It does require that you have the ability to manage data governance in a more sophisticated way. But I do think that is a difference between now and, 10, 20, 30 plus years ago, right? I think that's an important thing to understand here. It is, and also to be fair, it is still emerging, right? We haven't like fully solved, everything is perfect. We can take in any particular data set and understand it immediately. That's going to be important for, more research, like you were just mentioning, Corey, to understand whether these predictive models function better when they have, more member reported data and different other types of data sources. So I do think there is, just agreeing with you, Corey, that there has been a development and a change and a growth in that over time that gives us the ability to better incorporate and use these types of data. I remember from earlier in my career in health IT, just this idea of just disregarding the data that members provided or patients provided in a clinical setting, just this culture of disregarding the data as not reliable, they don't know what they're talking about their own health, just very paternalistic things, and that's changing over time.
Yeah, and we see that, and I think it makes total sense, particularly given the emphasis that the industry and practitioners within it have placed on things like SDOH data, and the fact that in our business we're seeing more and more health plans include questions related to SDOH built right into their annual health risk assessment surveys for their membership.
Yeah, definitely.
I think it's interesting, right? So as a payer or payers, most payers, they ask for a lot of data, whether it's a health risk association, an HRA, health risk association, sorry, assessment. It's an HRA, or when you're on the phone with a care manager, you're on the phone with an outreach coordinator. We are asking for a lot of data. And if any of you have called into your health plan recently, one of the things that you find is that you have to give your name, your date of birth, or your member ID number once, twice, 3 times, right? and how frustrating that is when you finally get through to someone and you get to the right person in the organization, and then they ask for it again. And my thought always is that if you're asking me for all this data, then why are you not using it?
You better
And I can
have it, you
get,
better record it so that, and you better be able to use it in the future so
yeah.
I don't have to answer these questions 100 more times unless it's relevant. Like picking up on that, Vanda, can you give, some more specifics around examples of how plans can or are using those self-reported data to better understand or manage, members that are rising, higher risk? Can you talk more about that, please?
Yeah, absolutely. I think to your point earlier, one of the most important things is going to be governance, is understanding and being able to sequester member reported data specifically against the transactional data that you have. Once you have it within your system, if you're not making it available to your care management team within your care management platform to be able to understand what's transactional versus what's member self-reported, we in the Medicaid space, a lot of the plans will have the race, language, ethnicity, phone number, email, contact information from their state partners. We know that many times that's not the most current data, whether it's a member preference on how they prefer to be considered from an ethnicity standpoint, or their contact information for phone call or email. You have to have that data available into your care management. You have to integrate it within your care management platforms so that your care managers, when they're on the phone, can have an informed conversation. Because like I said before, if I have to call you, if I'm calling you and entering in my number 3 times, or if I've given you this information and you don't remember it, you've lost the trust of that member. And that's really important. I think some plans, have done that really well, where they integrate data and then they're able to really address unmet needs. Other opportunities are, integrating it into your risk models, understanding what that risk profile of your membership is, either at the individual member level or at an aggregate level, because that is part of what you need to be able to understand how to operationalize and really operate your plan effectively. I think the other real strong area, the area that's coming kind of really an opportunity, if you're not already doing predictive analytics using some form of ML or AI, that this is the opportunity for you to start to understand. My suggestion would be to start small, because you don't want to drop an AI solution into millions of rows of data, because that can go wonky, or that could take a left turn really quickly. But start small, start to understand where your opportunities are. Look at a subpopulation in an area where you really have some opportunity, or you have feet on the ground that you can truly impact, and you can start to build and design your programs using that data to address the needs of the community there.
Mm-hmm.
That's great.
And the bit you said about AI, Vanna, I think is really important, because I think it is really only now where, and I see some of the questions in the Q&A that are sort of part and parcel to this. We've really only recently gotten to the point where AI and generative AI are sophisticated enough where you can take some of the concerns that I'm seeing in the QA about member self-reported data, particularly the unstructured data nature of it, and start to pull it apart and make sense of it and put it into a structured format such that a health plan can take action on it. So I really do think that, with particularly in our industry, where there are rightfully misgivings about the application of AI against decision-making related to patient care, this is one area where AI and generative AI can be really, really informative, where if you, and I respect exactly what you're saying, Mana, and I agree, don't just slap an AI model on millions of rows of
Totally
data.
right.
Heaven
Please don't do
forbid.
that.
Please don't do that. But in a selective way,
But
and again,
somebody will or has, right, Corey?
right,
And that's
For
why you
sure.
have to say it.
exactly. But if you can take it to something, and again, to be selfish about it, because this is kind of the context I come from. If you put an AI model on top of responses that you're getting in free form, if you're allowing it in your HRA, and starting to parse out what is consistent about those responses in unstructured data, it starts to shed light on some of the things that your member population might be worrying about or attending to that might not be in the very quantifiable questions that you have in the other sections of your HRA.
Yeah,
Yeah, there's
definitely.
so much gold in that, in those unstructured data, that members are sharing with us or sharing with their providers. And I think, to answer some of those questions, yes, there's going to be an integrity element to it that you have to be really specific and deliberate about. It goes back to, don't just drop an AI model on top of this, because there is no one solution. And you want to look at this, and you really want to take baby steps. You want to be consistent. You want to always go back and look at it. You want to review. You have to understand the data, and that's going to be consistently changing. So it's not a one-time effort, which is the other element, I think. And the third thing, before I give it back to you, Lisa, is really, you need to train your staff to understand the differences in the data that you are displaying.
Yeah, train your staff, not just your model.
Yeah,
exactly. Because we are inherently, from a technology perspective, we're comfortable. We're informing the model. We know that 3 rounds, we've done UAT, we've done QA, it's good to go. But really, it's about the staff, the users that are going to be using this data, and how they are engaging with your membership through this data. And it is meant to be informative. It's not meant to be exact.
Yeah, and all of that transactional data, again, it's so structured, and we have so many decades now of understanding how to process and use that, and also where that interacts with the actual, going back to the engagement with members from plans or plan sponsors. And this is a different ballgame, so to speak. I want to go back a little bit, Corey, and just see if you have anything else to add on any sort of overlooked insights that health plans can uncover through the well-designed HRA process. Like, let's talk a little bit more about those insights you can get from HRAs.
I think the biggest one, I love this question, Lisa. The biggest one that we've seen are activities of daily living and their contribution to what will inevitably go on to show up on your HOS survey. And this is what we found. So we run a lot of HRAs, and what we found in one large national payer is the responses for ADLs actually had a knock-on effect that maybe you wouldn't expect. Members who have higher numbers of reported needs related to activities of daily living have a lower perception of their own health, right? So, and that kind of stands to reason. It makes intuitive sense that if I need help with transfers and bathing and toileting and so on and so forth, that I'm going to feel sicker. I'm going to feel worse about my own health. The unexpected outcome of that is the more ADLs I have or need help with, and the lower perception I have about my own health, the lower perception I have about my health plan. It shows up in HRAs, it shows up in pre-cap surveys, it shows up in CAPS results. And so what is unexpected and maybe not intuitive about the kinds of things that you can glean from member reported data coming to you from a required, or if it isn't required, then certainly an extraordinarily valuable piece of member self-reported data that you get ostensibly and ideally every single year, are the number of places where members are reporting that they need help with activities of daily living. Because if there are more of them, they're going to feel worse about their health, and they're going to feel worse about your plan. So if you can get ahead of and start to articulate to that membership that these are the places that if you're reporting needing help with these things, we have resources and benefits to support you in them, and make diligent efforts to get those resources in front of and into the hands of members in such a way that they take advantage of them. It's going to have the knock-on effect of better outcomes on your CAPS score, because members who have fewer ADLs or are getting help with them are going to feel better about themselves from a higher perception of health, and they're going to rate you better as a health plan. Unexpected, but we found it across a big data set. And I'm pretty confident in that being a truism related to ADLs, and an unexpected thing you can find in your HRA.
Yeah,
I think it makes so much sense, Corey. I love that.
Definitely. Well, let's go right in from there because I think you just flagged, right, the response on activities of daily living, which makes sense to us to somewhat intuitively that if you have if you need more assistance with your ADLs, that's a red flag. Let's talk more about other sort of red flags in HRAs. Vanda, do you want to talk about any insights there for plans and plan sponsors in those key signs that should be acted on immediately, like ADLs or anything else?
I mean, I think ADLs is probably a really big one because that is it's a true indication of not only physical status but emotional status. I think, like Corey said, is if you can't get out of bed, you're probably struggling, in emotional needs as well. And I think many times as we think about these HRAs, we are really incorporating the information. We're thinking about it in terms of how we can use it to prevent ED or ER utilization, prevent inpatient readmissions, prevent inpatient admissions. We should also be thinking about it in terms of how we can design and implement any types of behavioral health programs that are targeted through this data. I think that's a really important element of it. The other places that we see where the HRAs really can kind of surface information is some of the more, traditional SDOH transportation needs, food insecurity, housing insecurity. Those are areas that you have to be able to pay attention because now you've got a host of information on these members. And it's going to be a matter of slicing and dicing and really being able to create that subpopulation. And it will go back, like Corey said, it's going to come back to your CAPs. It's going to come back to your HOTS. If you have members that are struggling physically, it's going to have an impact on their mental health, and how they're reporting out on any of the mental health outcomes measures. So I'm not sure that there's really anything in that HRA. It's long, but let's be honest. It's a long, survey if you're thinking about the CMS version, and some of the state ones can be just as long, if not longer. There shouldn't be anything that could not be useful. It's a question of you as an organization. I would again say think small. Start with subpopulation. Start with a grouping of measures that you have the most responses to. You would see that the responses are most informative or concerning, and start to build from there.
Yeah. Any other red flags, Corey, that you see, or other things to pull out?
Well, what's interesting, I want to comment on Vanda's very astute observation that these surveys are long. We found ourselves at Icario doing more consultation with health plans lately about best practices for HRAs. And it's related to exactly that because we've got health plan clients whose HRAs are 50, 70 questions long. What we find, and plans do have some latitude to bring the number of questions down, particularly in the DSNP space. We found that optimally 21 questions is about the sweet spot. And there are ways to get there in the way that you cast those particular questions that allow you to make the HRA and the experience more compact, while not giving up clinical value. One example that comes to mind is we've been working with one client and they ask a binary yes/no question about medications. Do you take medications? Yes, no. There's not a lot of value in the response that you're getting to that, not clinically. The follow-on question they ask is, do you need help with those? Enormous clinical value in do you need help with your medications? But the better way to ask it in the first regard is how many questions do you, or how many medications do you take? 0, 1 to 3, 4 to 7, 8 or more. Asking this same question that you would, it gets you this, or asking the question differently rather, gets you the same binary answer of yes, no, I take medications, which, as I said, in and of itself isn't of great value. But now we've got a little more insight into the number of medications and the potential number of comorbidities. and the potential for, do you qualify for MTM, that opens up a whole cadre of opportunities for follow-up with that member from pharmacy resources, from care management resources, and so on. And then you also follow on with the natural extension of the original question, do you need help? If the answer is yes, and I've got 8 medications on board, gosh, I hope that's making somebody's chase list. But it's a far more, it's that kind of modification and consultation that we're doing on the construction of questions within the instrument that health plans may or may not be thinking. If in the HRA world, HRAs typically live within quality or in operations. And if you're an operations person, you're probably responding and thinking about and being held accountable for the percentage of survey completions per C05 that's going to go into your star rating. In the advance notice that came out in January before the administration changed hands, there was some recommendation, do we, don't we, retire C05 in the MTM measure, because quite frankly, we don't care as much about the process-oriented measure of completions. Did you, didn't you take your HRA? We care much more deeply about the
Classic
outcomes.
process measure that
Right.
that doesn't give you any information.
And it certainly doesn't drive outcomes.
Right.
And so
Yeah.
while ultimately there was no decision on that, the intent is there. CMS is signaling they care more deeply about what we're doing with these data that members are giving us than the did you, didn't you of completing the survey itself.
Yeah.
I would agree, Corey. I think there's too much emphasis on completing a survey, checking the box. I think there's too much emphasis on, closing a care gap.
Mm-hmm.
Ultimately, we're so focused on, as the payers or as the stewards of this information and these processes, we're not focused on the outcomes. We're not focused on how we could or should be truly impacting the patients, the members, creating programs that really can change the narrative or change the paradigm. We're focused on checking the box, and that's a train that could crash pretty quickly.
There's some value there, right?
Based
To
on
if
some
you're
of the
thinking on
things
the
we've
provider side, right? Providers, it truly is, money reimbursement that they need if they're able to close those gaps for real. Obviously, just checking a box and nothing meaningful happening isn't adding a lot of
Right.
value. But you're totally right, and it actually brings us into sort of building on that same question for you, Vanda. So once a self-reported data reveals a potential risk, so this is when Corey was speaking in my mind, I was going like alarm bells, because great, the member has told us about these ADL challenges with the ADLs, SDOH problems, don't have transportation, I'm food insecure, my housing is insecure. Okay, then what do you do? And the risk of gathering those data from taking that from them in a survey and then not acting is really high. You can actually actively harm people by gathering those data and not taking any action. So once we have those, the risk has been revealed to us. What do we do? How do we organize teams to get moving and actually do more than just check the box here?
Yeah, I can say this, having been in this space for some time, we're not very good at organizing the teams to be agile and to create a more sustainable approach to addressing that information as it is captured, identified, real time. But that's really, in any of the attendees that are here today, or as we think about what our opportunity is we see a lot, we hear a lot about breaking down silos. Unfortunately, the silos are it's not just, continuing to build up, they still persist in most organizations. I personally believe data can help break some of that down, because the more data that you have, the more data that you can make into information and make it into insights is helpful. Unfortunately, volumes of data and large kind of databases or as you think about as much data as you can get, most people get intimidated by that. And so we have to ensure that as organizations, we're creating a simplified view of what's the problem you're trying to solve and how can I solve it, right? So if the problem that you're trying to solve is that from your HRA data, you've identified, like Corey said, you've identified that you have a group of members that have some serious ADL challenges, can't get out of bed, can't feed themselves, XYZ. What programs do you have to make sure that you are addressing that member's needs? Is your care manager in touch with them? Are they sharing what some of those community resources could be? Are you talking about bringing in home health? I can tell you just from a recent personal experience, just the understanding of what services might be available to a family member that is in significant need as they move from an inpatient facility to the home. It is like pulling teeth, trying to figure out, where do I go? What do I look for? What's the true quality metric? Because there's options to look at, and where's the data that's going to make me most comfortable in making a choice?
Yeah, definitely. Corey, anything to add there on how we move teams to action once we have these data?
We're talking a lot, and I love what Vanda said at the end about don't get intimidated by the data and what are the insights you can draw from it. We're doing a lot of work in what we're calling constellations of conditions, and really what it boils down to is, and again, coming from the perspective of the guy who's doing HRAs, right? But the stuff we can learn from an HRA, that's not going to show up in claims, at least not initially, if ever. So the things that you can learn from an HRA, if you are, for example, a member with congestive heart failure, the literature says that congestive heart failure, you're going to cost the health plan $30,000 a year, and that's just with CHF. But that's going to be in claims. We already know about you as a member. Maybe not as a new member coming in, and that's something we're going to learn in a hurry, right? But because you're likely to have a claim this year, but you're going to cost the system $30,000 a year for CHF. But we likely know that already because of claims. What we might not know, and we might be able to gather from your responses to your HRA, is that you also have additional underlying coronary artery disease based on your medications and the things you say you're being treated for, et cetera, et cetera. That may not show up in claims, but you're an odds-on favorite now to cost the system about 50% more, anywhere between, about $16,000 a year more for between a fatal and a non-fatal AMI, right? Add to that something that's almost never going to show up in claims for most members until, frankly, it may be too late, is an undiagnosed serious mental illness, where now you're talking about another third on top of all that. So taken together, these constellations of conditions where you've got an underlying diagnosed condition, and some serious comorbidities that aren't going to pop up in your claims file, and you've got a member who is never going to make your radar from a care management perspective, but who is certainly in a corridor of rising risk, who is an odds-on favorite to downstream, cost you more and have negative outcomes if you don't intervene in time. So what we're seeking to do is identify those constellations. What are the constellations, the combinations of factors that are common, can be identified by an HRA, and have the most potential for costly negative downstream outcomes that we can identify and intervene on, hopefully, in the nearer term. So that's where we're trying to help health plans identify these sorts of things and give them the tools to take action, because your care management team doesn't need one more chase list. They don't need more to do. But are there non-human interventions that you can enact in real time as members hit submit on that HRA in order to put them in touch with resources for the benefits you're already providing that don't necessarily involve a human intervention, but are connecting with that member in real time?
Yeah, definitely. Go ahead, Vanda.
I was just going to say, I love that idea of something that kind of can be almost that real-time response as the member completes the HRA, because so much of what the payer will do is take the data and it takes time to integrate it. But if you have some initial opportunities for information, for whether it's materials, collaterals to review, or guidance on local community, resources, I think that's really important. I think the other thing, if we just think that as I think about your specific question of what payers need to do is really have that team that is not just the care managers, because a lot of times we're relying on the care management staff to do the outreach, to be that face of the organization. But you really do need a team that understands, or that's cross-functional with quality, that has some risk stratification, analytics information. You need a team that's going to have the broad spectrum of understanding of your operations that can really address and make sure the care manager has everything they need at their fingertips.
Yeah, that's what I was going to pick up on a little bit, is that, there are also potentially other strategies and partnerships for plans in this case, right? We have increasing growth of community information exchanges, social health information exchanges here in California. There are a few that are kicking off their work and integrating with broader health information exchange systems. And so those are places that health plans and potentially plan sponsors could partner. But you're right, there needs to be, we can't wait for any delay. There's less of a delay with, data that aren't transactional, like claims data, but there still is a delay because these are usually big companies who have, very complex data systems to integrate, but you don't want to lose that sort of action point there. Which is important. I also wanted to note, this is related to this area, and that is specifically into the world of plan sponsors, usually employers, who obviously are responsible for, all this work is administered through health plans, but they're responsible for paying, and they have usually also personal relationships with the members, with the employees or the beneficiaries of those plans. And there's just a really fantastic series in Relentless Health Value, which I recommend to folks who are interested. Incredible podcast, DC Richter. And they talked a lot about high cost claimants who are, dramatically a huge amount of spend for plan sponsors. And in this case, because it's so new to really understand that the incredible amount of cost and probably personal distress for those members, those plan sponsors are just working directly with those members, and they're doing whatever they can do. And that just shows you that, like, they need somebody to, to work directly with those members or those employees or those beneficiaries, because there's usually, like, nobody has done this. Nobody has done we did the HRA, and then we tried to very quickly sort of close some of those serious gaps and help solve some of those problems for members and for patients. And so it's a problem that is only getting bigger, and we need to be able to sort of bridge that gap between the data that we gather and that we receive, and actually helping stop the metaphorical bleeding for these members and patients, right? It's a big one.
Yeah, I mean, so well said, Lisa, because, you see it all the time. We want more data, give us more information, tell us what you need, but 45 days later.
Right, that's not going to work.
It's just not going to work. And as we continue to see some of the challenges in state and federal funding for these community resources, the opportunity to truly have the impact is going to continue to slip away from our fingertips. Because now, if our community resources are getting strapped and we don't have the data, or we don't have the programs designed to really support the efforts, all we're going to see is the challenge continue to grow.
That's right. So we've got a number of questions. Let's just redirect a little bit there. We don't have to answer them directly right now. We'll look at them in a minute. But some of them seem to be about, like, how you actually integrate these data. So maybe, Corey, if you can jump in on that, and we can, and Vanna, join in. Like, it seems like there are some general questions about the challenges. How do you incorporate those data? How do you into risk stratification systems, into care management systems? How can you potentially overcome those challenges? I'm seeing a little bit of that, and that's kind of what we wanted to also add on here.
Yeah, and they're really good questions, and unfortunately, I don't have a silver bullet answer to them, right? Because the answer is, well, it depends, right? It depends on the the quality of the data, the structure of the data. There's I talk a lot with my teams about there's data acquisition and then there's data use. And sort of these are two key tent poles that we struggle with all the time, right? How do you get the data and then what can you use them for? So the integration into systems, I think, is a key challenge and one we're going to have to continue to wrestle with. But it's going to be is going to be trench warfare, right? Because it's going to be system by system, health plan by health plan, health system by health system. Because I saw someone reference interoperability, and we've seen the challenge of interoperability take shape over the course of the last, in my experience, decade or two, where there is such the challenge to interoperability is our willingness to share data with each other in what are otherwise competing infrastructures and competing business practices. So I think we got to wrestle to the ground some of those fundamental what I'll call business challenges first. But I think the how do we integrate these data boils down to the tactical elements of it in a given system are going to vary. But the way that I think about it all the time is how do we get these data into our systems in such a way that we can take advantage of them in real time. The way I think about it is within the context of what I refer to as the finite and knowable, right? When we ask questions of members and they give us responses, we already know what they're going to say, right? We know the answers. There are only so many reasons a member can give you for why they don't take their medications. There are only so many reasons that your member will give you for not getting a flu shot or giving an AWV. There are only so many reasons why a member ends up in the emergency room 6 times a year or the hospital 3 times a year. And we know we know the answers to those questions. We just don't know who's going to give them to us yet. The argument I make is that it's less about the way that we wrestle those data into this system or that system, and more about the fact that we already know the answers. So there is no need for this delay that we enact. There's no need for this linear process that we go through. Instead, what we advocate with our clients is if we know that Alice is going to tell us that she doesn't take her medications because she can't get to the pharmacy, then we immediately, the minute she tells us that, we connect her in real time while she is captive in that member engagement, in that moment of influence. We connect her with transportation benefits and resources so that we're knocking down that barrier to care. We didn't know that Alice was gonna be the one to tell us, but we knew somebody was going to. And that is true in virtually every question that we ask in an HRA, in a pre-cap survey, in a formal cap survey, in a HOS survey. Anytime we inquire of a member, what's going on in your life, we already know the answers. We just got to figure out who's going to say what to us. And the minute they do, have a program idling in the background, ready to roll, that's already approved and set, so that when they tell us that answer, we're responding in real time.
Yeah, very good. Fatima?
I would say, kind of taking it to a little bit of a 50,000-foot level. Just having read the questions. Our systems are not designed for the volume and types of data that we are now looking to integrate. If you have a transactional system, it can barely manage, the Z codes that we're adding in, let alone any member reported data, et cetera, and then be able to maintain the provenance and the integrity of those data, as well as the cadence at which we might be receiving that. So that's number one. That's going to be our issue. That is just the foundation of where we are today, until there's some new kind of system design as it relates to that transactional process. Okay. And then you add to that the data it changes today, and it's going to continue to change. We are still evolving in terms of what it is, what data we're looking to capture, what level of specificity, how we're going to use it, what that's going to mean. And that's that's an evolutionary process that we have to be able to understand and be comfortable with. There's nothing about what we do anymore that is an exact science. If you ask me on how to use the data, how to create how to create a space within your organization. It's about creating models that are based on assumptions that you have spent some time to consider and understand, research them, understand them. What are the assumptions? Test them out. And then you have to consistently test them again. You have to go back and test it over and over again as you see, because your data is going to change. And there's going to be different types of data that are going to be entering into your system. To me, it's a bit of you can consider it a bit of a marriage between data science and behavioral science. Like Corey was saying, if we think about the questions we're asking, we already know what the answers are going to be. It's a question about how do we use data science to then and layer on top of it behavioral science within the data as well as externally with our interactions to create programs that are going to be responsive.
Yeah, and we have so many excellent questions. I'm going to defer most of the sort of more technical questions about AI, just because that's a whole other webinar, which maybe we'll be able to do in the future. But there's a really fantastic question here from Brooke about state-funded health plans. She says, can you speak to, in general, the state of HRA data for state-run health plans? For example, is HRA data consistently gathered and utilized for patient members? Is that data available in a structured format to provide to providers in a timely manner? Anyone have any response on that before we kind of try to close this out with some parting thoughts?
Sure. Just real quickly.
I can definitely answer that. Oh, sorry, Corey, go ahead.
You go.
No, I was just going to say, ask your plan partner. Yes, it should be available. Most states require HRAs. The degree at how they require them to be completed or completion rates varies by state. For a managed Medicaid plan, which is what I'm assuming we're talking about here. But the data should be available, and if they're not sharing it with you for your panel, your member population, it's something that's a fair ask to ask of.
Yeah.
And in the absence of a reasonable response of, oh, here you go, because as an entity, this belongs to you, there's always the FOIA request. And in any state, that should probably, net good results. But I hope you don't have to go that far.
But yes, just to confirm,
I think the question is whether or not they're
available.
It's going to be about how they can share it.
Right.
And that may be something you need to work out with them. It should be a conversation that you can have with your plan representative. Yeah. And if you don't get the right answer from the first person, my suggestion is always go to another door.
Yeah. Keep asking. But you would certainly would think that plan sponsors and Medicaid, that they would want providers to be able to act on the results of those HRAs and risk assessments. But it is always, there's always lots of bureaucracy and layers. So I think Vandana's suggestion is a good one to keep asking, because it should be there. And it's just a highly valuable source of member information. I know from the HIE and the Community Information Exchange community, they've looked at, supporting that and being part of those processes. Some places that's happening. And so, this is an area I think we should all be looking at really carefully. I know we are running out of time, of course, just like we predicted. Can we just talk quickly about any just relatively quick advice you might have for any health plans or interested parties who are just getting started with using self-reported data? So just give me a few moments on this before we look at the future of self-reported data. Vandana, you want to start?
Sure. I think I've said this a few times, start small. Don't try and boil the ocean on this. I think that the data that as you receive it, think about it and how you're going to identify any opportunities, what you're going to develop in terms of a program, who you're going to assign to that program, and then what you're going to do to monitor it. Think about that acronym, IDAM. And that should at least give you a starting point on moving forward.
That's great. Corey?
I talk about this a lot because there's a separate thing that we do at Icario, and it's all about that, getting members to do the thing. Getting members to take an HRA is not an easy prospect because a couple of things are true. We have failed to this point, and we're hoping to help shape this and change it, we failed to help the members see what is in it for them. Health risk assessment, even by virtue of what we call it, a health risk assessment doesn't indicate to a member that there is value for you, dear member, in your responses to this survey. Secondly, when you're talking about plan sponsors and health plans, particularly in the government space, we've struggled, we failed in that regard to become a brand that consumers care about. I joke all the time, I'm a Banana Republic guy. If they ask me to fill out a survey, I am going to fill out that Banana Republic survey because they're a brand I care about. Work hard as a health plan to become a brand that your members care about. It's not an easy task because when NPS scores for health plans are what they are, it's very difficult to reshape the narrative in the relationship with a member such that they see you as a consumer brand the same way they see their car or their or the airline they fly or the coffee they drink in the morning. But that's the level of brand affinity health plans need to aspire to in order to make sure that when it comes time to ask those important questions of your members, that you're getting the responses that you're hoping for.
That's great. All right, we are really almost out of time now, so I'd love to just get Corey, maybe you can continue here in terms of like, what do you think the next 3 to 5 years of self-reported data looks like? Give us a brief vision for the future and any sort of calls to action for the broader community.
I think the future looks a lot more like data-driven intervention that doesn't feel impersonal. I think what separates most of healthcare from the rest of the consumer culture, like we talked about a second ago, but part of it is how dependent on humans the healthcare infrastructure is, and in many cases it should be and it needs to be. But the places where it isn't necessary to have a person directly interacting in real time with a member, where we can use digital interventions to get members engaged, but really kind of keep that powder dry for those and save those costly human interventions for cases where we can't motivate change, but without that digital intervention feeling impersonal. I think that's where it's headed, where the jokes we make about how the AI voice is so obvious compared to what those genuinely personal interactions can be digitally is where the future is.
I like it. Vandana, close us out.
I think the future is messy. And I think it's going to continue to be messy because our systems are messy, our processes are messy, and our data is messy. And I think the organizations that can work within that system and really create some simplification and some line of sight as to what their members need and how to really address that are the ones that are going to be successful.
That's great. Those are both really interesting and important closing thoughts for us here. There's a lot more to do. Obviously, please reach out to any of us, and we would be happy to build on this in the future. Thanks to Health for hosting this conversation. Health has recorded it. They will be sharing it, so no worries on that. And we just really appreciate all your time. Thank you, Corey. Thank you, Vanna. And we will all talk soon. Thanks, everyone.
Thank you to Icario and to everyone that joined us today. Please visit our website at community.hlth.com to catch up on all Health Go Live webinars. And join us in Amsterdam June 16th through 19th for Health Europe.